Okay, we're now live.
Lovely, thank you, Jane. Right, we will make a start. We're aware that Carsten isn't with us and hopefully will join us shortly. I've got a housekeeping to read out. So, good afternoon, everyone, and welcome to our Governing Board meeting. This is our first attempt at live streaming for the board. So, to introduce myself, I'm Dr. Elizabeth Fellows and I'm chairing the meeting today. We are meeting virtually in response to the limitations placed on governance by COVID-19 pandemic. Members of the public have been invited to view this meeting via a link available from the CCG website. Papers for the meeting are also available via the CCG website. Today's meeting is being recorded so that in the event of a failure of the technology of the streaming bit, it can continue anyway and will then be uploaded onto the CCG website as soon as possible on the conclusion of the meeting. The papers have been sent to everyone via email and they are now colour coded to try and help with scrolling through pages and pages. So if you are referring to something in a particular set of papers, it's well worth mentioning the colour, which will help people find them. Please. Board members, you're requested to keep your microphones on mute and to only turn these on when you're called to speak. Try not to use the chat function. And we will aim for people to be using the raise your hand, and if you can't raise your hand, wave, and we'll try and manage it that way. I would like to run through who's here, and we'll do that in alphabetical order, and I'd like everyone to introduce themselves and give your title. So Helen, can we start with you?
Thank you, the Chair. I'm Helen Atkinson. I'm the Interim Director of Public Health at Portsmouth City Council.
Thank you. Karen?
Hello, I'm Karen Atkinson. I'm the registered nurse for the Governing Board.
Linda?
I'm Linda Colley, GP and Chief Medical Officer for Portsmouth CCG.
Margaret?
I'm Margaret Geary, a lay member of the Portsmouth CCG.
And Alison?
Hello, I'm Alison Jeffrey. I'm Director, Children, Families and Education for the City Council and responsible for health commissioning for children for the CCG.
Thank you. Carsten, I think you've arrived now.
Yes, I'm here. My name is Carsten Schaff. I'm one of the GPs in Trafalgar and I'm one of the clinical executives for Portsmouth CCG.
Thank you. Graham?
Hello, I'm Graham Love. I'm a lay member on the Portsmouth CCG board.
Nick?
Hi, I'm Nick Moore. I'm a GP in Portsmouth. I'm one of the clinical execs on the CCG.
Jackie?
Sorry, hello, I'm Jackie Powell. I'm one of the lay members for Portsmouth CCG.
Dave?
Good afternoon, I'm David Scarborough. I'm Business Manager for the Trafalgar Medical Group and I'm the Practice Manager representative for the CCG.
Andy?
Good afternoon, I'm Andy Sylvester, lay member, Portsmouth CCG.
Simon? Simon GP?
Oh, I'm Simon. I'm a GP and I'm also one of the clinical executives with Portsmouth CCG.
Michelle?
Hello, I'm Michelle Spandley. I'm Chief Finance Officer for the CCG.
And Tawinda?
Hello, I'm Tawinda Uppal. I'm a secondary care consultant on the CCG.
Lovely, thank you very much. And we have apologies from Innes Richins, Chief of Health and Care Portsmouth, and David Williams, CEO of the City Council. And I think that is all. We've got people in attendance who will be introduced as they present to us. So moving on to register and declarations of interest, we have to raise that Jackie Powell has a direct conflict of interest for an item under the Chief Clinical Officer's, Chief Clinical Officer report. And at that point, from a technical point of view, we think the easiest way of effectively asking you to leave the room, if we were in a room all together, would be to turn your microphone off and turn your camera off, so you can watch as a member of the public, but you take no part in that conversation. And then when we finish that item, you can put your camera and your microphone back on, if that's okay. Does that fit the bill, Andy, as our conflicts of interest guardian?
Yes, that's fine. Thank you.
Lovely. Thank you very much. Has anyone got anything else to declare in terms of the meeting agenda? Do I take silence and a few shakes of the head? Oh, Nick, you've raised your hand.
It was just in relation to the register of interest. I'm not sure whether we've actually come to that yet, but it's just an incorrect thing that needs to come off my entry. It mentions me being a shareholder of the PPCA, which is no longer relevant. So it's just in terms of the register of interests.
Right.
But no conflicts to declare for the rest of the meeting.
No conflicts for this meeting. If we deal with the conflicts, then Jane can take you off that bit. So no other conflicts for the meeting. Any changes to the register, Jane's favourite occupation, apart from Nick? Everything else all right? Lovely. Right, so moving on, we've got the minutes. No, so sorry, going back to the register, we've got the full register of the CCG this time round. Is that correct, Justina?
We've got the committee, the register of those members on committees.
Committees, right, I'm with you. Okay, so we're happy that that's okay, everyone?
Yeah, thank you.
Thank you. Right, moving swiftly on. Minutes of the last meeting held on the 20th of May. Have people got any comments, corrections for that? Let's get to it. That's a white paper. Yes, Jackie.
Sorry, so on page 4 of the minutes, under Primary Care Commissioning Committee, the fourth dash down, it says, supported the application to close the Stubbington Avenue and Hanway Road premises within the next 6 months was also considered. And I wondered if it should be the application to close Stubbington Avenue, blah, 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 within the next 6 months was also considered and supported. The sentence read strange to me.
Right. I think it doesn't make sense.
Yeah.
Can we just check what the decision was then? And
yes, so was the decision supported?
Yeah.
Yeah. So we just need to take out was also considered, don't we? Support application to close Stubbington Avenue and Hanway Road premises within the next 6 months.
Yeah.
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 Are people happy who were at that meeting that that's true? Thank you.
Another small typo on page 9, second paragraph down. First sentence, David asked about the additional funding for practices around COVID-19 related costs and if there was any indication if the additional funding support will as opposed to with.
Right.
Tiny type. That's it.
Jane, have you got those?
Yeah, got those.
Lovely. Anyone else? Did I see Margaret waving at me just now? No? Right. So are people happy to accept those as an accurate record of the meeting?
Yes.
Lovely, thank you.
Agreed.
So we've then got the next paper in pink, which is the summary of actions. Most of which have been completed and hopefully everyone's received the things we said we'd send to people and that. The one thing that's in progress, I blame on my appendicitis, in that I haven't written to thank the CCG team for all their cracking work over the last 4 months. So I am now back properly full-time, and I will be getting that sorted in the next few days. So apologies for not having done that. But are people happy the rest are complete as said?
Agreed.
Lovely, thank you. Moving swiftly on to Linda's Chief Clinical Officer's report. And Jackie, at this point, I would ask you to turn your camera and your microphone off while we discuss the first item. We will, of course, invite you back in to discuss the rest of the paper, but Linda's going to major on that first.
Yep. Thank you, Elizabeth. So for purposes of this meeting, I'm assuming everyone has read the paper, and so I was just going to focus on the 2 items that are in the recommended and actions requested section. So that's item 7, which is page 4 of the report, and this is regarding mental health services for children and young people. So we've recently been successful in our bid to enable to extend our mental health support teams in the city from 2 to 3, which means by 2022 we'll have full coverage of every school and college. And if you remember rightly, the mental health support teams look after the emotional well-being issues and the mild to moderate anxiety type issues that children have. So it's kind of the lower level work before they need CAMS support, and the staff are linked directly with the schools or colleges, so actually upskills the school workforce and makes every contact with the children count. So a really good approach to mental health of children in the city. To support that, there's been work looking at digital mental health services, and there's a lot available in lots of different formats, including kind of self-help websites where you can signpost people to, but also ones that have kind of chat facilities and online counselling. And over the last 6 months, the teams have worked with the partners across the city to look at what this could do for our children in the city and whether this is something we want to further develop. So the focus was on a blended care offer, so incorporating both self-help resources and online counselling, which would be operational 24 hours a day, 365 days of the year. And it's been looked at this as a good option and that we want to further progress this. So they have had feedback sessions with partners across the system to consider the benefits and how it would align with our current early help offer and the rest of our strategic ambitions. And the outcome of these feedback sessions has been really positive, and a consensus has been reached that a digital blended care offer will result in more effective integrated early help pathways and therefore lead hopefully to better outcomes for the young people and families. But as a result of that, it means that we need to give notice to the current provider of our counselling services, which is the Relate You Matter service, so that we can then go out to tender to procure a digital mental health service. It would take 6 months notice period to terminate the existing contract, and we have been in discussion with the current provider of this intent if we go ahead from the board, and it would look that the contract for Relate would therefore conclude on the 31st of December of this year if we go ahead and approve that. So I'm asking today for approval to terminate that contract with the current provider and give notice of the intent to tender for the digital mental health platform. Can we have that before I move on to the next bit?
Yes, agree.
Oh, we've got hands up going up.
Graham, is that hand up to say something?
Yes, please, Elizabeth.
Yeah.
Just a couple questions, if I could, Linda.
Yeah.
Although it's called blended, I'm taking it from the fact that it's a digital service. It is meaning that we will no longer do face-to-face in person. Is that the intention?
Alison, are you on the call? Do you have any more detail on that?
I think, yes, I am. Hello. I think that the blended reference would be to the fact that we'd be combining the digital offer with the offer through the mental health teams in schools. So the mental health teams in schools would be working in a combination, some direct with children and some working to support the staff in schools who provide direct support for children. So that's the sense in which it's blended.
And just to follow up, if I could, I suppose my question is a bit: are we possibly terminating a bit early or not? And I'm only thinking that in the sense of, are we really confident the 6-month procurement would be delivered in that time? And there could be elements of things like a second wave come along at the end of the year. Is that likely to interfere with any procurement exercise we start?
I mean, I guess the only thing I'd say to that is that the colleagues who would be working on the procurement have been working throughout the pandemic from home digitally, and there's nothing in principle, unless all of them were to become ill. I think our contingency planning will be fairly robust, that we'd be able to progress this work should there be a second lockdown.
Okay. Thank you.
So Andy next, and then Simon.
Thank you, Elizabeth. Yeah, I had a question very similar to Graham's, but my extra point on having read through it and looking at this is there's lots of talk there about young people and children, and these are people who may be in areas where access to the internet or the ability to get to a phone may not be that simplistic. So 365 days a year, 24 hours a day may not be good for them. There's families who can't afford an internet broadband connection in their home, so their only opportunity to access a system in a digital means would be going to a library or being at school, where it could be very difficult to speak to someone on a chat conversation with other people around. Has that been considered and thought about at all?
I think we will need to look at how we can make sure that, sorry, that was my front doorbell ringing, and I'm hoping that my other half, despite being in a meeting, will go to that. Yes, it sounds like he has. Good. Yeah, I take your point, but what we need to look at is what's on offer by telephone, whether there's some emergency telephone line addition to that, because I think we will need to take into account when we do the specification the needs of people who don't have access to the internet. Such research evidence suggests that the vast majority of young people do, and we also are looking at digital equality from the perspective of education. So the other side of my work, because obviously we need to make sure that children can access education if there's another lockdown. So we certainly need to make sure that those needs are picked up. I hear what you say.
Thank you. Simon?
Thank you.
Hello, it was just a comment really just with regards to finishing one contract right in the middle of the winter Christmas period, which classically is a time for high demand for some of these services, and just making sure that there is a fail-safe that should the new service fail to start, and for whatever reason that there is just a safety contingency, because it is a difficult time of year for many people.
I think that's a good point, and I would suggest that the governing body give us discretion to negotiate with the current provider over extension of that period if we find ourselves in a position where we don't have cover, because I absolutely agree with you that cover over Christmas is essential.
Thank you. Good point, Simon. Nick?
Yeah, it was just to clarify the point that Andy made. I think from my understanding, because this was discussed in some detail at CAG, was that there has been quite a lot of engagement, I think, with children, young people, and families, parents particularly as well, about how this works. Obviously, the issue you mentioned about 24/7 stuff, about what stuff is put on, the moderation of content and discussions and things like that. So I think those are points that are well known in terms of what's being worked through in terms of the plan for this. That's my understanding from the discussion that was had at CAG.
And Elizabeth, can I just mention, I think it's good that we can get this started as soon as possible, digital access, given that we're thinking there's going to be an increase in demand for this early help type offer with COVID and the effect on children. And so actually this will hopefully broaden out the offer and allow more people to access it. So I'm
not sure we've got to the bottom. did ask, will this offer include one-to-ones with children, even if that's virtually via Teams or WhatsApp or whatever, or is it only chat room style?
No, I think it was including one face-to-face, potentially one-to-one, as well as so it's the blended thing that Alison was mentioning, that it would be there'd be a range of things. So the idea of this, I think, was that it would be expanding access rather than restricting it from what we have now. Was that your understanding as well, Alison?
I believe so, but I wasn't at the clinical group, and you may be better informed than me, but I believe so, yeah.
Lovely, thank you. Andy, did you want to come back, or are you forgetting to put your hand down?
Oh, sorry, I haven't put my hand down. My apologies.
Can I just ask one question, Elizabeth? Sorry.
Margaret, yes.
I can't put my hand up.
No.
Yeah. Just to ask, there's a demand for online. Whilst we've been online over COVID, has there been a rise in demand for that kind of low-level emotional health service?
So, certainly in practice, we're getting a lot of questions from both parents and young people struggling with mental health that I feel wouldn't hit a threshold for CAMHS, and I've been signposting to what we currently have. And so, yeah, I definitely think there is. I've seen more of it over the last few weeks, I would suggest, just on my clinical lists.
And the platform provider that people have had discussions with has reported a very significant increase nationally in the use of its service.
Right, so as a board, if I can sum up, the suggestion would be some flexibility and an end date, so we don't have a hiatus at Christmas if all things go wrong. If that is possible, to look at that. But are people otherwise happy to go ahead with terminating New Matters and moving to this digital and blended offer?
Yes.
Yeah. People happy?
Yep, great.
Lovely. Okay. And so I would, at this point, like to invite Jackie back in. So you can turn your camera and microphone back on. Well, no, not your microphone until you're speaking, but and then over to Linda to continue. Thank you.
Yes, so sorry. The next one I was going to raise was about the end-of-life medication backup in community pharmacies. So Portsmouth is currently the only CCG within the Hampshire and Isle of Wight footprint that don't commission an enhanced service from community pharmacies to hold a stock of specified end-of-life medications. So currently the way we've worked it is the GP, knowing somebody's becoming end of life, will write a prescription that the family then fill at the pharmacy like normal and hold it in the household. And at the beginning of COVID, there was concern there may end up being a shortage of medication and accessible end-of-life medications, weekends, evenings, guaranteed, unless it's been pre-thought of. Sometimes it's quite tricky to get hold of these medications at the weekend and puts added pressure on the out-of-hours services. So a proposal went to CAG in May, Clinical Advisory Group in May, and the committee supported the proposal to stand up an enhanced service within 3 pharmacies, and they've been picked based on their location, so one in the north, one in the central and one in the south of the city. And the pharmacies are ones that already provide extended hours so that we've got enough cover to get the drugs throughout the period that we would need them, bearing in mind that the out-of-hours provider for overnight PHL have access to their own supply of end-of-life medications if it's needed. The cost of the service would be £300 annual payment to each pharmacy for participation in the service, and also is meant to cover in case the drugs they've held in stock go out of date and can't be used, which we expect to be very small volumes, but just to cover that. And so the board are asked to support this enhanced service for the 3 pharmacies to hold the end-of-life drugs, to make it more rapid for patients to get them when required.
Thank you, Linda. Any comments or questions? Nick?
I think that just a point of clarification again, just as having been the chair of the clinical advisory group, was that this was the proposal was for 1 year rather than it being a rolling thing. Obviously, so it could be reviewed. It was obviously just really in the light of COVID and what the demands might be on the medication. So rather than it being an ongoing thing, it'll be reviewed after a year.
So do we have support for that, or any more questions with that?
People happy with that?
Yes.
Yes.
Agreed.
Yeah.
Thank you very much.
So I
Right.
wasn't going to go through the rest of the report, but if anyone's got any questions about the report, obviously it is here and we can try and answer.
Right. Any other questions about anything else in Linda's report? No?
No, going on.
Yes, well done. Thank you very much for that, Linda. So we've got next is a COVID-19 update, and this is verbal from Helen.
Thank you, Elizabeth. So I wanted to mention three things. So the first being the outbreak plans that each of the local authorities with partners have been asked to produce by the end of June. So just wanting to say that we have worked well across the partners, including obviously working with the CCG, but our other health providers, the acute hospital and community trusts, and also other partners across Portsmouth to produce our outbreak plan. It is available on the Portsmouth City Council website. If you just do a search for Portsmouth outbreak plan, there is both the full document as well as a summary, easy read explanation for our residents. Although this is obviously a new plan and a requirement from central government, we have obviously not started from scratch. We've both built on previous health protection plans that we have through our local resilience forum, including our pandemic plan. But this is a specific plan. And of course, again, we have obviously been managing COVID-19 now for some months. So the work within the plan isn't completely new, but we are enhancing how we are working together as partners, both through the local resilience forum and then locally within Portsmouth between partners. It includes 7 themes, so how we will work and are working already with our care homes and schools, other high-risk settings and other locations, including, for instance, some of our more vulnerable residents like our homeless and residents who are currently in our hotels within Portsmouth. It also covers our local testing capacity as we take over more responsibility at a local level from central government, how we will work with our local health protection team, that's a Public Health England function locally, around how we work around contact tracing, both individuals as well as obviously when we've got risk of outbreaks in our community. It also includes access and the level of data that we hold, and I'll come back to that because I'd also like to quickly mention where we currently are in terms of our infection rates in Portsmouth and how we provide that data both to partners but also to our residents through our website, and then has a specific focus on vulnerable people, and particularly those that are having to self-isolate, either as cases, confirmed cases themselves, or as contacts of confirmed cases, so therefore have to self-isolate at home, and how we will support them if they don't have family or contacts locally who can provide them with food, etc., parcels. So that's also included. And then there's an important bit around the local governance, which again I will come back to. But the plan really sets out how we will work as partners together across the public sector and working with the voluntary sector to both prevent the infection rate of COVID-19, which is very low in Portsmouth, rising, but how we will also work together to manage outbreaks when we get to more cases that are related in any one setting. So I mentioned the governance there. So we have a local health protection board, which I myself, as the interim director of public health, chair, which has all of the partners mentioned already, including the voluntary sector, but it also has quite a lot of the different directorates within the council, like our housing, obviously education and leisure, as well as our NHS colleagues, including we have both the CCG, the acute hospital, and Solent represented on that board. We meet weekly, and it's basically how we work together, share good practice, but share intelligence and then share responsibilities as we actually follow up any possible outbreaks. And then we also have, which was a requirement from government, a local engagement board, which is member-led. And the board's responsibility is really to ensure that we are being transparent with the work that we're doing and how we are managing outbreaks and content of our plans. So Linda actually is on that as the co-chair of the Health and Wellbeing Board, with Councillor Matt Winnington as our lead cabinet member for public health, health and wellbeing and adult social care. So the role of the board is really to ensure that we're both managing our infection rate and our outbreaks effectively, but also ensuring that we're being transparent with our communities and that we're clearly providing evidence and data to our residents. So again, I just wanted to mention that on that website with the local outbreak plan is the easy read summary, but also we produce a COVID-19 intelligence summary presentation each week, and it is uploaded onto that website on a Friday afternoon, so that you have the most up-to-date information around where we are. We feel very strongly that, much like other areas that have been in the national media, it is really important that our local residents understand the local infection rates from COVID-19, so are making risk assessment decisions around how they are, obviously, whether they're going to work or whether they are socialising, and also just in terms of the decisions they make around contact with others. So as we, the important part of the plan is that as we move out of lockdown, because it's really important that we think about our economy, that we do understand the risk locally and that we are supporting people to make the sensible decisions so that we can move back to, I suppose, a new normal, but maintaining the really important government guidance around social distancing. So just wanted to quickly remind us, I know that it has been updated recently, but it's still two meters very clearly if you can remain at 2 meters distance from other people, and it is 1+ if you can't. But I would really advise and recommend people stay at 2 meter social distancing. It also provides all the information and support if people become symptomatic around how they can go home, self-isolate and take a home test with all of the details of how to access testing. So that covers in terms of detail on the website. We also publish the minutes of the local member-led outbreak engagement board, and that's also on the website. Then I mentioned that I would quickly update on the current data and intelligence. So we do produce, as I said, that presentation each week, which includes the current most up-to-date information about the number of cases of coronavirus in Portsmouth, but also includes other data like our death data. So just to give you a current update as we are today, we currently have, and it does seem too neat a number for today as this is the recorded meeting, but we do currently have 500 cumulative confirmed cases of coronavirus in Portsmouth, and that is from the beginning of the pandemic, so the period from March onwards. And if we actually look to compare ourselves, so that is a rate for us of 232.4 per 100,000. And to put that into a context, because it's important to be able to compare, so that means that obviously we've had since the beginning 232 people per 100,000 of our population in Portsmouth who have been confirmed. South East is currently, the whole region is at 376.1 per 100,000 population. And to put it into, you'll be aware, into a context, you'll be aware that the North East, North West have had increased infection rate recently, which obviously led to Leicester having to remain in lockdown. So their rates per 100,000, North East is 570.6 per 100,000 and North West 597.9. And then if we just look at the most up-to-date data, so that's of today, so we get this data on a daily basis. Just in the last 7 days, we've had 5 new cases of confirmed coronavirus in the last 7 days, in the last week. We've fluctuated at a very low level from 0 some weeks to 2, and the highest weekly or it's actually over a 2-week period with 10 cases. So what you're seeing is a very low infection rate in Portsmouth. And of course, it's really important that we encourage people to keep following the guidance, because that's what we want to do. We want to mitigate and keep that infection rate low and not have spikes or increases or outbreaks. So that's the most up-to-date local data. To put it into, also just wanted to mention, there is obviously a lot of planning going on both locally in Portsmouth as we work up towards our winter preparedness, but also across the local resilience forum to ensure that we are ready and have plans in place for, there is a proposed modelling around a second wave in the autumn winter. Now that's just modelling, which doesn't mean it's definitely going to happen, but it is without mitigating actions, it's quite likely that there will be an increase in cases as we move into winter, as we also see an increase in our seasonal flu activity as well. So I will stop there, and thanks for just giving that update. But I suppose my final thing would be to encourage the planning for our seasonal flu vaccination programme is being finalised, and it is likely that there will be increased people eligible this year, obviously because of COVID-19, and just really encourage everybody to have their vaccine when it is available, because that will reduce the impact of seasonal flu at the same time that we've got a likely second wave in coronavirus.
Well, thank you very much, Helen. And I think the people of Portsmouth should be commended for getting such a low infection rate. We're one of the most crowded, densely populated areas outside of London, and despite that, we've bucked the trend in the southeast. And I think, you know, we should be proud of our city to have managed that, because it's impressive when you quote those figures, and we're half the number up in the north. So yeah, good on you, Portsmouth. I always liked the city. So there we go. So have people got questions or comments to make on Helen? Yes, Jackie.
I completely echo what you just said, Elizabeth, as well. Really, really proud of Portsmouth. One of the things that's recently come up in the news is, has there been sufficient support? I probably think I know the answer for Portsmouth, but I'll ask for clarity. Has there been sufficient support for those in supported accommodation, which previously, according to national news, may have been an overlooked group?
Yes, I would like to say, Jackie, that I think the support has been very, very good in Portsmouth. One of the real strengths of Portsmouth is how the public sector, so obviously the CCG, the City Council and the voluntary sector and partners work together. And I see this every day. I've only recently moved to working in Portsmouth in February of this year, and I'm very impressed with all of that joint working, which has ensured that we are supporting our most vulnerable people, and that is, I can think you can evidence that in many examples. I think how we have ensured that, for instance, our homeless and rough sleepers have been both brought into accommodation but also supported through our homeless health team, and recently have all been screened or offered screening. How we have worked so closely together in terms of our adult social care and CCG, IPC leads working around whole care home testing, which includes supported living, or it will do as we move forward with whole care home testing. And I could think of many examples actually. Yeah.
The other thing that I think is quite significant is we're looking at extending the telehealth offer in the city out to our supported living housing developments. So that would be Milton Village and Maritime House and Brunel Court that I know of. There may be others, and that will enable those people to have access to support 24 hours a day from the nursing team. So we are working for those people directly as well. Andy.
Sorry, I thought I might have missed a little bit. I didn't quite catch what you said, Helen. So as far as the people in supported accommodation getting their PPE or their testing or what other support may be necessary. Understood the telehealth bit, but did you say that's just started, or that's been part of what we've been doing for a while?
Yeah. So access to PPE has been available since the beginning of the pandemic, and we've worked really effectively and well together across health and local government. We've got a PPE store, and all providers are able to access that store. And then whole care home testing was, I probably wasn't completely clear. So whole care home testing is a national programme that we're very much part of and insured, but it wasn't open at the beginning, so they prioritised it, and each month more sectors have come online. So it was only open for testing for staff and residents for dementia care and over 65 to start with. Extra care, supported living, LD, mental health is coming online, and because they have just moved from whole care home testing once to it now being a monthly cycle for residents, that is opening up in phases. So I suspect by September it will be in place to ensure. I mean, there are other forms of testing, of course, so individuals can do home care tests anyway and be supported to do home care tests, but that whole programme is coming online currently.
Thank you. Andy, and then Margaret.
Thank you. Helen, thank you very much for that. Helen, I heard you mention a couple of websites that I think you said were on the PCC page. Would you be able to send those through to us via Jane, if that's possible, and perhaps put them on the CCG website as well, just as we can link into that information flow that's coming through? It sounded so helpful. Thank you.
Yes, of course.
Thank you. Margaret? You're on mute, Margaret.
Yeah, thank you. Just wanted to ask how the arrangements for testing that you've referred to locally linked to the national testing arrangements in the city?
Yes, Margaret. So there is a great deal now. I know it was something raised at the beginning, and people felt quite strongly. Great deal of capacity for testing now. Most of it is nationally managed, but we have the ability to also manage locally. So there are several, without going into all the detail, but there's several pillars of testing. So you'll be aware that obviously pillar one, which is NHS testing, is both within the acute hospital for staff and patients. Then we have the ability, when we have a suspected outbreak, through Public Health England, of accessing also through pillar one initial testing to identify or confirm whether it is an outbreak, and then whole care home testing then steps in. We also have now a national testing site in Titner, which is open to the public, initially open to key workers and staff, but now open to the public. You have to book in, it's by appointment only. And we also have we have home testing now, so that's the national programme that's encouraging, and you'll have seen the advertisements on the television, anybody with symptoms to go home, stay at home, self-isolate, and apply for a test, which you can either ring up or go on the website. We also have what we call ad hoc testing that we can, working with the DHSC, bring in. I've mentioned whole care home testing, and that it is now reopened, and that is testing staff weekly and residents monthly in a cycle, and that's just getting underway again from the first phase. And then finally, we can identify high-risk groups. So we are currently, just as an example, in the final stage of the planning, whole homeless hotel testing for our homeless and rough sleepers. That will be imminent, and then we will also be getting access to what we call further testing capability from the DHSC in statics. And the final bit, which is how, if we, for instance, do move into a lesser situation where we are increased risk, increased infection rate and outbreaks, sporadic outbreaks in Portsmouth, we have a regional mobile testing units which can come out and test. So quite as you can, quite a lot of capacity now.
And presumably data is shared effectively between all of those
yes
points.
So, a very good question. So all of the data is in two pillars. which is pillar 1, as I mentioned, in the NHS, which is related to NHS patients, staff, and then pillar 2, which is everything else. It's all community testing. We get daily data, so it is obviously confidential data, and we don't share any PI data. Obviously, GPs get copies and access to any patients that they are seeing in terms of that testing data. But then the Director of Public Health, and it is only the Director of Public Health through password protected sites, and we've had to sign a data sharing agreement, gets local data, postcode, but not named data, and that's for us to support us managing outbreaks. So we do get that, and we share it obviously through so I've mentioned the slide set, the presentation you can access. The data is on there. I've mentioned some of it today, but it's not shared or personal details are not shared. So it's only to manage outbreaks. And then obviously Public Health England have access because they actually do contact tracing through the Test and Trace programme. They follow people up.
Thank you very much. Linda.
Sorry, I took my hand down because Helen mentioned what I was going to say, which was about the homeless healthcare. I was involved in calls last week about basically trying to make sure we can test even asymptomatic. If we're going to move people on from the hotels to shared living, for example, we want to make sure that we've tested and things. So yeah, Helen already mentioned it.
Lovely, thank you very much. So thank you very much, Helen, for a very comprehensive update. I feel much better informed. So thank you. Is that it for questions, and shall we move on? Thank you. So, finance and performance reports, Michelle.
Lovely, thank you, Elizabeth. I wasn't necessarily going to go into too much detail of the reports, but clearly I'm happy to take any questions if you've got any specifics relating to the reports. I'll take each one separately, just give a brief overview of where we are currently, remind you what sort of regimes that we're working in for each of those particular sections, and hopefully we'll be able to run through relatively quickly. So just to remind the board that we're currently working under revised financial regime process since the emergence of the emergency response to COVID-19. That said, we've successfully submitted our 1920 annual report and annual accounts, and I'm pleased to say that we got a clean bill of health from the auditors. It is up on our website now, so we have published them formally. We'll talk about that more in our September board as required. So just to thank all the staff members that are involved in doing that, because they had to rapidly do that remotely. Really good learning experience, but they all did fantastically well. So good news from that point of view. But in terms of the changed financial regime we find ourselves in for 2021, that has included an adjustment to our original allocations that we were talking about before we went into the COVID-19 response. So the report that you will see will only take us up to month 4, and we're currently awaiting further guidance nationally about how months 5 to 12 will pan out, and I'll talk about that in a little while. So currently we're working under a regime where we make some fixed payments to most of our trusts, and they've been nationally generated, and our allocations have been adjusted accordingly to sit within that. And the way it works is we've got an allocation. We also make a submission around any additional COVID-19 costs that we've seen, and then there's a top-up process. And the idea is to try and get all organisations to a break-even position on a monthly basis. And as you would expect, you're only seeing month 2, so we're a little bit behind in terms of some of those updates, and I'll talk about that in a second or two as well. As I say, that replaced our normal processes, and also just to remember, in a normal situation, some organisations would have been receiving some sort of top up anyway, so there was always some financial support going on in in the NHS in some way. So we're just using that money in a different way, I suppose, is the best way of putting it. So the month 2 numbers you're seeing now currently show that we submitted a deficit position of £2 million. That included £1.6 million of COVID-19 costs, and of that, the vast majority of that was around the hospital discharge programme. So this programme is to encourage movement of patients out of the hospital setting, where ordinarily there would have been some sort of process before that happened to establish whether they needed continuing healthcare, for example, or do they need social service support. And indeed, if it's social service support, is that support something that a patient needs to self-fund? So all of that was, if you like, put on hold, and patients had been moving through the system without that process happening. Hence why we have seen an increase in costs as a result of that. We are expecting, we have actually received £1.6 million since that report was produced, and we're awaiting the further 400,000 to make us to a break-even position. That is what we're expecting to see over time. We were due to understand what the financial regime might be from months 5 to month 12, and I heard yesterday from Julian Kelly, who is the Chief Finance Officer for the NHS, that they still have ongoing discussions with the Treasury about how the rest of the financial year will pan out for the NHS. And obviously the NHS is just one set of organisations having that conversation with government currently. So we're not really in a place yet to finalise what months 5 to month 12 will look like. So what they're proposing to do is definitely for month 5, we will remain in the financial regime as it currently is, with a view to trying to rapidly move towards a slightly different financial regime where systems will be given a budget calculated on current run rate and will be asked to live within that sum of money. So I suppose the way I see it is that we'll be given back some control over what we need to spend our money on. And alongside that, we'll start to understand other factors and expectations around the rest of the financial year. So a couple of the big things that are included in that is mental health investment standard. We're expected to achieve the mental health investment standard for 2021. And as we understand more of those changes, then clearly I'll bring back what's appropriate to governing board to make sure that you're aware of that. In terms of making sure that we have financial controls, etc. So at the beginning of the COVID-19 response, we reviewed all our procedures just to make sure that they were fit for purpose and that we adapted where we needed to do so to reflect that we were working remotely. So we just made sure that everything was still compliant, and I have to say that seems to have continued okay from then till now. So that's good news, and again, really great that the teams have managed to work in that way, because it could have been very, very different. And to that end, just to reassure you, Andy and I have been in discussion about the next audit committee in September, that we bring back a scrutiny item just to talk about what was our response, how did we assure ourselves that what we were doing was okay, and clearly we used benchmarking and all the information that was coming out. But we'll go through that process with the audit committee just to make sure that we add that level of governance and transparency about how we responded. In terms of some really good things that has come out of the pandemic, you'll know that we work really well with the City Council, and we've been trying to push that on in terms of financial reporting, etc., and the teams working together. I'm pleased to say that not only has the system working been enhanced by the way we've had to cope, but also our relationship with the City Council and indeed the City Council finance teams has taken a leap forward, and we are a little bit of an envy of the system around us, that we have such a good working relationship with the City Council. It's not always replicated right across the country. I was probably going to not say much more than that. It's obviously that's a whistle-stop tour of where we are currently. I was hoping to be in a position to give you a little bit more certainty about months 5 to 12, but we're not quite there yet, and hopefully by the time we meet again I'll understand that a little bit better, and we'll understand how our allocations will change for the whole of the financial year. Suffice to say, we're trying to make sure that we're prudent in the costs that we are collecting, having one eye to the mental health investment standard, make sure we understand the rules of engagement around that. And as you know, in Portsmouth, we do try and make sure that we address mental health issues, head on, as it were, to make sure that we are doing the best by our patients. Yeah, I think that's probably as much as I want to say on that part of the report. I'm happy to take any specific questions, or I'll move quickly on to performance and planning.
Thank you very much, Michelle, for that. Any questions? That Jackie? Go for it, Jackie.
You're on mute, Jackie.
You're still on.
Can you hear me, Michelle?
Yes, I can now.
Yeah. And it was just a quick one, looking at the report, and I really appreciate all the amazing effort that's gone into it, related to mental health, where there's increasing costs. I think that's with extra contractual referrals, or
Yes.
is it something else? Have you got NRC put down?
Yeah, you're right, Jackie. It is our old favourite on extra contractual referrals. We are, again, it's one of the benefits of having to work in a slightly different way. It is something that my team are now working really closely, more closely than we were before, with the team in the council and our own teams, obviously, just to try and understand some of the processes that go on around assessing patients, making sure that they're getting the most appropriate placements and the most effective, cost-effective placements as well. So I'm hoping, with my fingers crossed, that we might see some improvement in that particular line over the coming months, and also pushing on with the work that we had started with Solent around those particular placements as well, just because of course it's low volume, high cost, so hopefully we can get just a little bit more focus and around that area and improve our financial picture from that point of view.
Thank you.
Anyone else? Or shall we ask Michelle to move on to the next one? Thank you.
Yeah, okay, shall I go through? So again, the performance report is here more for information than anything else, because again, as we've moved into the emergency response, we're not really being held to account in terms of all these performance measures. But it's useful to know that we're continuing to continuing to make sure that we've got good data quality and that we understand how the performance is changing as a result of having to work in very different ways. You'll also note within the report that some of those performance measures have improved as a result of the slightly different way we're working in, and some of those have got worse. So in particular, the worsening areas focus mostly around the elective part of our agenda, and we know the reasons for that because of things being closed down. As we work through restore and recovery mode, particularly over the summer, we're hoping that quite a lot of that will get better, but it's not going to be back to the levels that we had seen prior to COVID. And also we need to make sure we have one eye on the fact that there may be a second wave, and we need to make sure that we're planning for that as well. Nationally, they are trying to encourage improvement in over 52 weeks in particular, in terms of the elective agenda. And again, we are trying to embed the improvements that have been made as a result of having to work more remotely. You know, use of NST, use of video consultations. So we're doing quite well in Portsmouth on things like advice and guidance, and Linda knows more about that than I do, and you guys know more about that than I do, definitely. So we just need to make sure that we embed those processes as we get into the restore and recover process, and indeed quite a lot of improvements in terms of use of digital platforms, etc., for primary care as well. So as patients, we're seeing that if we're having to attend GP surgeries, etc. And I suppose the other thing in terms of the restore and recovery part of it, we need to remember that our staff need to take holiday as well, and we're coming into the summer months, so although nationally they might quite like us to get on and do some of the waiting list issues, we do have quite a tired workforce in terms of certainly the front-facing acute and mental health and community services. So we just need to be good employers from that point of view. We need to make sure that people take breaks as well, don't we? That really was just like an overview of where we are. We are trying to improve performance as best we can, noting that we're probably not going to be going to solve all the issues in the next 6 months.
Thank you very much, Michelle. Any comments or questions for Graham?
Graham's the one. You're on mute, Graham. Lovely.
Just, well, half a comment, I think, and half a description. I was expecting the incomplete waiting list size to actually have gone up, and I noticed it's actually gone down, and I can see some pros and cons on that. But was just after a bit more explanation as to what you think's contributed to that most.
I think it's probably because the referrals are not coming through in the same way. So your adding on rate is less than potentially you're taking off rate. Portsmouth hospitals have tried to continue with their cancer work, and they are utilising the Spire Hospital as well, at Havant as well, in order for that to happen. So I think again, we're quite lucky in our patch that they've been able to do quite a lot of that work ongoing. And in terms of advice and guidance, I believe Portsmouth might be top of the shop in terms of utilisation of advice and guidance, and that's all down to GPs wanting to work in a different way, as well as obviously the trust wanting to work in a different way as well, and making sure that we are mindful about other ailments that people are still getting, aren't they, despite us being in COVID-19, and making sure that we're doing the right thing by those patients too.
Thank you, Nick.
No, thank you.
Yeah,
That's
it was
really
just a point. Sorry, did you call me Elizabeth?
Yes, Nick.
It was just to follow on from Michelle's point about advice and guidance. We're also currently working with UHS Southampton, who provide our neurology service, to try and expand advice and guidance, because that's a service that has had quite long waits. We're trying to get a service or something that expands in providing that as well to GPs. So because it's popular with all the other specialties, so it's something else that's worked on as part of the ongoing plan.
Yeah, thank you. The level of people over 52 weeks is increasing though, so you know, that is something that again the teams are trying to work on to see if we can stand up some more capacity, and if we did that, what would I'm going to say the pecking order for want of a better term, but you understand what I mean, is do you look at those people that are over 52 weeks, or are there some more urgent cases that might need to come in front of them?
Pick that clinically urgent stuff, exactly, and sort them out. Margaret, and then Karen.
I just wanted, I'm not sure I didn't understand this, but having read the diagnostic it felt from what I read that it would be that for certain pathways it would be a really ambitious recovery length of time because diagnostics won't be working as the speed they were, what pace they were for some time.
Okay. So I'm catching part of that sentence. Did everyone else hear it?
I don't think so. So
I
Margaret,
didn't hear it.
I think what you're asking is the diagnostic targets have plummeted, haven't they? And how are we going to recover that, given that we're still working in COVID-19? I think that's your question, isn't it?
I think it is because I mean,
Linda, are you yeah? Are you able to answer the question about diagnostics? Because I personally couldn't, so I'd have to take that away if you're not able to answer immediately.
No, I mean, what is important is urgent diagnostics are still being done, and actually we're probably accessing things quicker, but it is incumbent on the clinicians to be very clear about what management would be changed by having the diagnostic. And obviously diagnostics are being prioritised for things like query cancer and that kind of thing, but we're working together to try and make sure that when we request, we're very clear about what we want and why, and then actually we're finding that we're getting quite a rapid response in terms of diagnostics in the community. And as I say, in the hospital, they are having to prioritise, aren't they, for either COVID or cancer kind of urgent things. And as we go back into the new normal, I think that will be the way of working. It'll be very clear, why do you want it? What will it change? And using it with the advice and guidance to say, is this needed? And so that we're only doing the correct diagnostic and doing it once.
And the other thing there is that some of the procedures are much more affected by COVID than others. So upper endoscopy, for example, is a aerosol generating procedure, is therefore into the very tricky category and very hard to do. Whereas bone densitometry, if we're looking for the strength of people's bones, is an easy one, can still happen, and that's why that's cracking on. So that's why you've got the marked discrepancies in the weights. Any other?
I think that was behind my question was some need for some more clarity about where it was having the most impact, and if it's not on the urgent, then let's say that, and that's fine.
Urgent is still happening very much so. We're doing better than many areas on the urgents because of our access to Spire. Simon.
Just to add to that point, now because of the increased use of advice and guidance, consultants are now also doing some requests internally rather than GPs having to request from the outside back into the system. So that may change figures somewhat as well.
Okay. Thank you. Right, if that's it on that report, can we move on?
Karen's got a hand up.
Oh, sorry, Karen. I do apologise. I missed you.
Sorry, I'm probably repeating things, but I just know that NHS England have asked systems to restart cancer and elective treatment. If we've achieved 6 out of 8 of our standards, does that suggest that in Portsmouth we didn't actually stop that work? Is that what we're saying?
Yeah, that's right. We didn't really stop it. They cracked on. Because of our opportunities, we were getting people processed. And certainly that's definitely the feel in primary care. We have had new people diagnosed with cancer and their treatment started.
Lovely, thank you.
Yeah, well, I believe we're in a slightly different position, and with the financial regime changes, the independent sector contracts, I understand, are going to be extended to at least October, which will mean that we can still utilise that capacity without having to worry about who's paying for it. And again, an update will come as part of the guidance as to how that will extend into future months as well.
Linda.
Sorry, I just wanted to say we are concerned, obviously, as a health system, that people aren't presenting with their symptoms that may be suggestive of cancer. Given this is a public meeting, I would implore anyone in the public, if they think they've got symptoms that are concerning, to contact their GP. We are still open and we are still working.
Yeah, thank you. It's a good reminder. And there certainly was a drop in presentations early on. It does feel like people are starting to come back, but we definitely need them to continue to come in.
And in terms of the planning paper, which is quite a nice little segue, isn't it? I thought it would be helpful just to inform the board where projects have been not stood down but paused for a while, but which ones are being taken forward, any new ones that have come on stream. So the 111 First would fit into that as an added extra. And also just to update you again that, you know, as a system, we were always trying to work collaboratively, and I think this event has really pushed that process forward, and discussions, you know, are bearing fruit in terms of you know, changing the ways we want to work. A very good example of that would be the advice and guidance, where we've been trying to push for that for some while, and we're making progress and huge inroads where we never thought we would make such big inroads. Yeah, so I really wasn't going to say much more than that as an introduction to the report. It's there for your information in terms of progress, and if you've got any questions, concerns and stuff, I'm more than happy to take them back, and we'll see if we can address them. Looks like Jackie's waving.
Yeah, sorry, and I was on mute. Managed to turn
I can see you, Jackie. You're in the centre of my screen, so I can see you waving at me.
Very pixelated, but you're there.
Good, yeah.
Yeah, thank you. Yes, it's been a fun. One was a build on from the previous conversation around working differently, and especially how we've worked with cancer. And one of the things in the paper that I thought was interesting was the creation of a standalone diagnostic centre. And I didn't know whether that had been progressed or moved forward, or if there's anything to share with us along that. And the other one, not related, was around the early discharge planning. And there was a comment about the not having enough resourcing and staffing for this service to be sustainable. And I wondered if, well, what's happening?
So, Simon, can you comment on the early, the cancer centre stuff? Have you been involved? If you get that.
So, only loosely, but I know that there is a rapid diagnostic service kind of undergoing a pilot at the moment through Wessex, and that I think is in a phase 1 pilot, I believe around Dorset, but they're looking to roll that out with it eventually reaching phase 3 by next year, which is looking to introduce a kind of a local rapid assessment for cancer with anyone that has concerning symptoms without strictly falling into certain regions. Normally as GPs we say, well, if you have certain symptoms, we think it might be, you know, respiratory, or it might be lower gastrointestinal. Whereas this is, if you see someone who's lost a lot of weight loss, but perhaps they're quite young, you know, you can't obviously say, well, this is a chronic cough, or they have blood in their back passage. Can we send them to a one-stop shop where they'll be checked to exclude any significant disease? So this is a project in the works. It's not come here locally, but as far as I'm aware from this communication, we hopefully will be seeing it next year, but that's the most I know at the moment.
Thank you.
Thank you.
And can anyone answer the question around early discharge? Anyone have any information on that?
Elizabeth, the only thing I could add to that would be around the hospital discharge programme and the fact that currently there are no blockers in terms of moving patients on. So I think you'll find what the teams are now concentrating on is making sure that they can work together and be empowered to make the right decision, and it doesn't matter who you work for. So trying to break down those barriers to make sure that we get the flow right. And then of course the early discharge planning is identifying the right patients that might need future either social services or CHC from their you know, when they indeed, but for some of them it will be before they get into hospital, but for those that are emergencies it will be about, okay, Mrs. Miggins has arrived today, in what time span do we think she's going to leave the hospital, and what would she require for that to happen? That's what that comment is around, and it's that bit that people are taking the advantage of not having such a full hospital to understand what are the barriers for that happening. Yeah, so that once we come out and are in sort of more normal times, that we've got that embedded in terms of it's what's best for patient and how do we make sure that this patient leaves the hospital in a timely fashion, because we know if people stay in hospital for longer than they need to, that is not good for their health either.
Thank you.
I think there's some really good work as a result of the pandemic situation we're in, is pushing that further forward than we probably would have done at that point in time. Yeah.
So are you informed, Michelle,
Yeah.
that actually there is the staffing and the financial means to actually embed some of this? Because the question was around, there was concern about that.
Yeah, yeah. And that is something that they talk about on a daily basis. And it isn't necessarily that there's no finances, it will be around recruitment and retention, I suspect, predominantly. Yeah.
Okay, any other questions or comments on this? And I will say thank you very much, Michelle, and to the team for producing these very informative papers. It's really, really useful to see the updates. Thank you very much. So we move on to Justina and the annual complaints.
Thank you, Chair. Just to introduce myself, my name is Justina Jeffs. I'm the Head of Governance at the CCG, and I oversee complaints as part of my role. So what you've got in front of you is the complaints annual report. I wasn't intending to go through it in detail, but I did just want to pick up a couple of points, if I may. So just to acknowledge that the CCG actually receives a very low number of complaints in total. This year we've had 18. There were 21 from the previous year. However, we are signposting complainants directly to provider services much more frequently. So they have a choice whether they'd like us to deal with their complaint or whether they want to go directly to the provider involved, where it does involve a provider. Portsmouth City Council actually run our complaints service for us, and actually we do that through a service level agreement, and it seems to work very well. And they also deal with any questions, queries around the Parliamentary Health Ombudsman, of which we haven't received any over the past year. The Quality and Safeguarding Committee receive quarterly complaints reports, and they oversee kind of the learning from some of those. And I think the only other thing I actually wanted to mention as a real positive was the fact that in meeting with a complainant earlier in the financial year, it's actually encouraged us to completely change our process and rewrite our complaints policy in order to be much more user friendly. So we've had good input from the complainant and their family, and actually that's now available to everybody, and we've had some positive feedback on that.
Lovely, thank you. And it's good news to hear we've responded to public's input, so that's great. Any other comments, questions on this report? Karen.
Yeah, just a small point. I note that we've got some demographics around the complainants. I wondered if for the future we perhaps should look at ethnicity. Maybe that would be an appropriate.
Yeah.
We should break down the complainants in ethnicity, I think, for the future.
Thank you. We can certainly try. We do ask people to respond to us, and we send out surveys after their complaint has been responded to. However, not everybody responds to us, so we will.
But there may be trends if we can get the information. Thank you.
Thank you. Anyone else? Is the board happy then to accept this report and agree to have it published on our website?
Agreed.
Lovely, thank you. So over to Karen for the Quality and Safeguarding reports, please.
Yes, hello. The Quality and Safeguarding Committee continue to meet monthly. We met this morning, but the report that you've got for the Governing Board today was discussed at the June meeting. I've just got a few things that I wanted to draw your attention to, which are on the covering page, but I'll just go through them. the first one is that, as usual, we've got within the report we've got the risks that we are monitoring alongside services. They haven't been updated in the report because, understandably, the services have been concentrating on their COVID response. So it's not that our teams haven't been connected with the services. It's just that we haven't worried about so much about prioritising those risks. Having said that, some of the risks have actually reduced. The ambulance waits at QA, we haven't had that concern, and the concern, that quite significant concern we've got around UTH, UTH at St Mary's and their clinical vacancies has been less of an issue because they've reduced their activity around some of their services. But the one risk that we are closely monitoring is during the pandemic, we've had the transfer of wheelchair services, and AGM are now our provider of services, but also to say that the audit committee have asked for a deep dive into wheelchair services, so that will be happening in September. So we're not overlooking any of the risks that are within the report. It's just they're not particularly up to date. The quality team, yes, like I said, the team are connected with the services, and we're aware that all of the services, as understandably, are now going into the sort of recovery and restoration phase. And what we're very mindful of is that it's introducing some new emerging issues for people, particularly around capacity, as the services are trying to introduce social distancing measures. So, for example, at QA Hospital, there's an indication that they may need to reduce their beds by something like 56 to be able to incorporate social distancing measures. So the team are just aware of that and are just working with services just to see if there's any impact on quality generally. There's also concerns emerging around the emotional well-being of staff, and some of those staff, either because they've been working from home and that's created a problem, but also a lot of them have been working with COVID positive patients, and they've kept the momentum going, but now, as we've said previously, they're exhausted. So the teams are supporting services to come up with ways of supporting staff in services. So I think there's something like a relaxation cafe going on at QA Hospital, and they're offering specific clinics to staff, but I think there's still more to be done, and they're working with the teams to do that. The last point is around just drawing the governing board's attention to the report, pages 15 to 21, which talks about the work that has been done with our care homes in Portsmouth. So this is work that's beyond sort of business critical work, and it's work to support the care homes. We know that the care homes nationally, or there's been negative media interest nationally around care homes, but I think it's fair to say that our team, alongside Portsmouth City Council, has been working really closely, and our care homes in Portsmouth have been well supported throughout the pandemic. Prior to the instruction to go out and support and give training, our teams were already supporting our care homes. That's really all I wanted to draw your attention to, but obviously happy to take questions.
Lovely, thank you very much, Karen. I'm going to come in and use my prerogative to ask the first question. For PPCA, I am aware that they've taken on more work and they've been doing more for 111 over the last few weeks. So they are busier. And then I read in the report their Chief Quality and Operations Officer has left and has not been replaced, and that work is being done by the directors. That makes me a bit anxious at a time when they're expanding and they're doing more work, that they've lost such a key player and a key role within the organisation. And I just wondered what the QSEG had felt about this. Was it something that was discussed?
It was something that was discussed, and we equally had concerns. I think what the assurance we've had is that there's quite good systems in place now, and that the team are generally working to those systems, so that's working. And what they're doing is taking the opportunity to review the need for that role, and so they've delegated some of the tasks that person would have done, and taking the opportunity to review the role. But it's really the robustness of the systems that they've got in place now that they didn't have in place before that's supporting them. But yes, we equally were concerned, but I think at the moment it seems to be that they are still being well supported by the other people.
Okay, right, thank you. That's my question. Little doubt still in my mind, but there we go. Open to other people. Anyone else got questions? Jackie?
Thank you, Karen. I think this is a great report. I really do. I find it very easy to read and very accessible. I was going to pick up a little bit around what you were saying about the COVID-19 and looking at our care homes, and it reflects the question I asked earlier, is does this work include supported accommodation in terms of you being able to give them support and make sure they've got PPE and this sort of thing?
I'm going to say yes. Certainly we went out to 39 care homes, but because the CCG are working so closely with the City Council, then yes, they have been quite responsive to all of their needs. So if and I think there's a weekly briefing session where all supported homes, care homes, domiciliary homes can feed into that, and then if there's any issues coming out of that, they've been able to support them. So I haven't got the specific data, but that's my understanding. Yes.
Okay. And supported accommodation, I mean, like sort of places where people with maybe learning disabilities may be housed, and that's sort of very vulnerable need.
Well, so the learning disabilities people in supported living are covered under the 39 care homes.
Yes.
So
yes, it's not just nursing homes. It's been mental health, learning disabilities, and nursing homes.
So 39 care homes includes those. When you use the term supported living, those are more like the places I mentioned earlier on, which is Milton Village, Brunel Court, Maritime House, or whatever that's called. In that, those places are people living in their own flats with care on site. So it's very different. And supported living is outside of the care home remit, but we are looking to move into do more, as I said, telehealth care home teams, and that they're looking to expand. But learning disabilities, mental health homes are all covered in the 39 and have been right from the beginning, because they are within that CQC registered homes, which is a different thing.
Very. Well, yeah, it is, and it clears up where my thinking was. Thank you, some sterling work.
Okay. Did I see Margaret waving at me? No. Okay. Oh, Margaret, did you want?
No, sorry. No, I was just confirming that.
Okay. Lovely, thank you. Anyone else? I'm just very conscious we haven't heard from Dave or Tawinda this afternoon. I just wondered whether, have either of you got anything to say? Or Carsten?
No, my questions have been answered actually, so.
Great, that's good. Thank you, Tawinda.
Elizabeth, no, it may be unusual, but I haven't had any questions. I haven't had any questions today, but I will take the opportunity just to follow up on the one that you asked, Karen, about the PPCA Chief Operating Officer. Is there a time frame for that review? Because the weeks are ticking on.
Good call.
I actually can't recall it. I thought it was the end of the summer. I thought in my head I've got the end of the summer, or September, but I can't actually recall it. I'd have to go back and check for you.
Thank you.
Thank you.
That's good point. And Carsten, have you got any?
I'm fine. No, I'm satisfied with everything. I'm just timid
No, so no need for that. But thank you. Right, are there any other questions for Karen? Everyone happy? I think we have to say yet again, thank you for a very comprehensive report. So thank you very much. Right, moving swiftly on, we are now at the point of the end of year report for the medicines management team. And we are going to have this presented by Jo, who is our acting director for medicines optimisation, being supported by Simon Cooper, Director of Medicines Optimisation. So I think we will move over to you, Jo.
Hi, yeah, I'm just going to attempt to share my screen. I'm not very good at this, so fingers crossed I get it right. Hopefully it's that one. Ah, does that work?
Yes, that's fine.
Can you see it? Because I can't see it at all.
I can see it.
Yep, can see
Okay,
that.
I think it's because I've got multiple screens up, so I don't actually know which one you can see. Okay, so as I've already been introduced, I'm Jo Williams, Acting Director for Meds Optimisation. That's just until the end of August, while Simon is supporting the NHS BSA. So that's only 3 days a week. So he is around as well, and the both of us will be able to take any questions at the end of the presentation. So we were asked to put together a brief presentation, because I think last time you guys met, there was a scheme that came forward and there were questions around that. So I'm planning just to cover a couple of the schemes. So Linda's already covered one of them, the end of life scheme, the pharmacy first minor ailment scheme, but also our end of year report. So in terms of our team, we're quite a lean team. We're made up of pharmacists and pharmacist technicians. The team, they support practices around things like promoting safe and quality-driven prescribing, while also trying to remain within the allocated budget. We're also supporting care homes, so providing clinical reviews, and also supporting safe processes around medicine, so things like administration, storage, and ordering from the community pharmacies. We also have a member of our team who is allocated as a pharmaceutical advisor, and that is supporting some of the commissioning of enhanced services from community pharmacies. So the end of year report, that was circulated with the agenda. So again, I'm not going to go into too much detail, but again, please do ask questions at the end if you do have any additional questions. So our end of year prescribing spend was 33.7 million. That was an increase of 6.3% from the previous year, but that increase is similar to the other CCGs local to us. In terms of items, the total number of items prescribed was a smaller increase of only 1.3%. We did see an increase in the number of medicines issued in March, which is likely due to patients trying to be prepared for COVID, the outbreak and potential for not being able to get out as easily. But that is expected that the cost pressure for that will be reversed in the early months of this financial year. The safety and quality programs that we cover, so that's a sequin, that runs from July of last year and into this year. We have been making some progress with those programs, and we've got some cost orientated programs around those, and these are all doing well. Again, they were covered in the report and some of the graphs are in there. And again, we're comparing well against our local CCGs and also nationally with those. We've also been involved in a national pilot from NHS England looking at supporting patients to reduce the risk of stroke by prescribing blood thinning agents. So there's a potential for that increased spend to have been seen in the cardiovascular system when you look at the breakdown of our spend. And also to mention that we have been reducing the number of kind of business as usual activities. So when COVID hit, we put a pause to some of these programs, and we're really focusing on supporting GP practices, particularly with digital initiatives, one of which was the electronic repeat dispensing. where this allows medicines to be authorised by a prescriber for a course of up to a year, and then they could be issued in either 1 or 2 month batches depending on what the prescription request is by the community pharmacy, and that's to help support social distancing with GP practices, community pharmacies and patients. So that's the end of the year report. Okay, so I think last time we sent to you the Pharmacy First scheme. So this is one of the CCG commissioned enhanced services that runs from the Portsmouth City local community pharmacies. This is allowing patients to access care for minor ailments. It's been commissioned from around 2005 from selected pharmacies, and then it was rolled out to all pharmacies in the city from 2015. So the service allows over-the-counter medicines to be issued and charged to the NHS without requiring a prescription. That's for eligible patients, so that patients would be those who don't pay for prescriptions or those in full-time education up to the age of 24 years. So that encourages patients to seek help from their community pharmacy instead of going to their GP practice, so ideally freeing up some of those appointments rather than people pitching up to the GPs. Next page. We had a review of the scheme since there was advice from NHS England saying that we shouldn't be prescribing medicines that can be purchased over the counter. So the review showed the majority of issues of medicines were for children under the age of 13 years and also generally for households on low incomes. And the majority of the consultations took use during standard opening hours, so that would be kind of your standard GP appointments that would potentially have been taken up. So we took a proposal to the CCG CAG, so the Clinical Advisory Group, and that was supported. So we've moved to the scheme focusing on medicines for children, which generally are slightly more expensive, particularly liquid preparations, and the focus would be on those homes or families with low incomes. So being a deprived area, the CAG were concerned that if we did just completely stop the scheme, that those patients just would return back to the GP practices and request the prescriptions because they couldn't afford to access the treatment otherwise. So in terms of the cost of the scheme, for 2018 to 19, the scheme costs around £24,000. And it's estimated that if this was provided by GPs or other providers such as minor injuries unit, it would have cost more like £44,000. So there is a saving. That's a Pharmacy First scheme. And then Linda's already mentioned the end of life medicine scheme, which we asked to be supported by the governing board today. I don't think I actually need to cover much more because I think Linda actually covered it really well. So it's a scheme that is generally provided by most of the other Hampshire Isle of Wight CCGs. The reason we hadn't previously commissioned this scheme is because we are quite a compact geography, and actually we have really good access to pharmacies with over 30 within the city itself. But it was felt that in order for us to prepare for a potential second wave, the scheme being low cost should be supported. So again, that's why we've brought it back here for support. I think that's it. So are there any questions? Like I said, Simon's going to help.
Lovely. Thank you very much for that, Jo. That was a very useful run through. So, yeah, I was going to say, if you end sharing, that's great. And I can see people a bit more.
Yeah.
Right. Any questions? Shall I go straight to you, Jackie?
And I think your report sort of answered it. Was the Isle of Wight seemed to have done exceptionally well?
Yes.
And I wondered if there's anything for us to learn from that, or is it? I don't know what are they doing there that we could be doing as well, or is it different?
I think Simon, with his national hat on, may be able to help me out with this question.
So having spent some time working on the Isle of Wight, it is different, and they do commission a variety of things off FP10. So where there are items that can be supplied away from FP10 via a different route, they are very early adopters of that type of role. What I would need to understand is a little bit more detail exactly why they've dropped so much. So I think there has been some work mid-year to take some of the items that they use on FP10 off FP10, which obviously will influence that and skew that data set. So it's sometimes we are not comparing quite like with like.
Okay.
And along those lines, if they've taken the item off the prescriptions, they're still paying for those, but they're not visible in the prescribing budget. That's the
Absolutely.
right, isn't it?
Yeah.
Yeah.
I see. Yeah.
And probably,
right.
probably this may well be more described better in that the islands are probably utilising stuff that others have done in order to progress their improvement. Does that make sense?
No.
Except we've done them if it's such a good idea.
So they're learning from others to improve their financial position. Yeah.
And to reassure the board, there are very strong links and a very safe environment with the heads of medicines management across the whole of the system, and that goes to the acute trust as well. So pharmacy as a world is a very close world where we can share best practice and likewise can ask for help within that. So if we do find something that another CCG or trust is taking on that we think we would benefit from, then it's very quickly reviewed and taken on.
Brilliant. Thank you. That's helpful.
Any more questions? So I will come back to, have we got something to learn from the islands? There was one particular thing around, I presume it's a different way of purchasing diabetes medicines that they're doing, because their diabetes endocrine stuff was down. Have we got things to learn from them?
I've not picked that potential one up. There have been the Isle of Wight historically have taken on a lot of branded generic prescribing. And have started to move away from that recently. So if there have been some price changes on specific brands, their movement to come away will show in a percentage reduction.
Right.
So it could be down to some of those things. So it's the devil's often in the detail with some of these things.
Yeah, that's why I was asking really rather than anything. That's fine. So any other questions? So nationally, we have been good for a long time. Are we still as good as we were, despite cost pressure?
I think it's fair to say we probably don't hold the same position as we were previously. There are some pressures coming in, particularly in this year, and linking very closely with finance to make sure they're aware of anything on the horizon. There is likely to be a hit from Category M very soon, so that came into July out of sequence, so we're going to be hit by things like Category M, and there is also a national review of how branded generics that sit with, I don't really want to go into the massive detail, but how branded generics sit within Category M and how they are reimbursed, because there's some technicalities around whether reimbursements currently come through nationally or come through CCG. So potentially there are some changes within this year, but the detail at the minute is months away.
Right. And Michelle, you've got something to say?
Just to add in terms of the overspend, although we had that little spike in March, it's predominantly been around pricing throughout 1920, wasn't it, Simon, rather than numbers?
Yes, so we've, if you look back at the report, we are relatively static in terms of our cost per item and cost per patient.
Yeah.
Although there is obviously month-to-month variation, so a lot of the pressure is around pricing, and that's where we tend to aim our cost savings plan, working with GP practices around that type of thing to counteract that. But we are at the whim of category M changes mid-year, which is frustrating to say the least.
Yeah. And last question from me is, we're obviously good at the repeat dispensing compared to national figures. Is it worth pushing further on repeat dispensing to hold our position? Because I know that the original plan around repeat dispensing was it reduced waste in the system, so we're not chucking medicines away that aren't used. Is there a feeling that that's to be exploited further?
So I would probably I'm going to shoot myself in the foot here. I would counter that we are still up there. We are probably in the top quartile for ERD, but we are slipping down nationally.
Right.
We are slightly different in terms of our performance as the CCG in that we have quite widespread adoption across all of our practices, but our current top practices are in the region of 30-31% of their patients are currently on repeat dispensing. If you consider that to the highest single practice nationally that's on 80% of the patients are on ERD, you can see that it's very difficult for me to sit here and say, aren't we wonderful?
Yeah,
so I think there is a huge amount of gain, and part of the work that I'm doing with the BSA is providing practices with lists of patients who are suitable for ERD, so to shortcut that process to prevent practices having to go through the hard yards to try and identify those patients. There is that national push. Portsmouth Medicines Optimisation Team working practices to push that on and take it on further. It was less around, to be fair, it was less around the cost savings to the budget, more around reducing workload for GPs in terms of that repeated I don't want to say a tick box exercise, but that repeated process where you know a patient is absolutely nailed on the medicines and completely safe, and going through that process is adding less value than could actually be used. So it's around supporting that workload. There was a particular highlight during COVID in terms of reducing footfall into practices and potentially into pharmacies as well, which is why we worked with Edwalla nationally in terms of reducing the consent model. So that's been relaxed currently until September, I believe. If that hasn't quite come out yet, it will be on its way out. They're looking to relax that till September. So we are working to push that again, and I think as Portsmouth we need to support practices to all get to at least that 20% level and push on from there.
Lovely, thank you. You both mentioned BSA on a couple of occasions. Perhaps for everyone, could you just confirm what that stands for?
That's the National Health Service Business Services Authority, and their role in terms of this is that they capture all of the prescriptions that come in once they're dispensed from pharmacies, and they trigger the reimbursement back to pharmacies for their cost of their drugs and services, and subsequently charge CCGs for their prescribing. And within that, obviously, there's a rich data set that is at patient level but not patient identifiable, that we can use for identifying variation in prescribing practices.
Lovely, thank you. Michelle, you've got your hand up, but was that an old hand? Yeah. Any other questions? Now I've stopped whispering. So thank you very much indeed for this presentation and the report. It's really useful and helpful, and the board's happy to accept it.
Yes, thank you, Simon. Yeah.
Thank you. Thank you very much, Joanne, Simon, for this. Right. So moving swiftly on, we have the GBAF, which is here for noting. Sorry, I'm just scrolling down to find it. I don't know if everyone else has got there already, but so any comments or questions really, because this is just for noting. people got any questions around it?
No.
No. Oh, Jackie again. Hello. It's a good job you're in the middle of the screen. Makes it easy to
Yeah.
tell you.
Oh, it's around the patient engagement. I wondered if it was worth adding as part of our assurance that we've got a joint health and care Portsmouth comms and engagement team. That's it.
Right. So which one's that?
So that is graph 002, patient engagement, sources of assurance.
So as a mitigation, it says about the Health and Wellbeing Board annual report includes patient engagement activity.
Yeah.
Is that enough?
I just thought I thought it was worth mentioning because our plans are well organised, thought through, have a strategy, and a lot of that work seems to happen, especially when we've got a new joint health and care Portsmouth comms and engagement team. That's
okay.
what I
So do you want to put a suggestion forwards as to how that should be phrased and let Justina know, and then we can have a look at it? Is that okay? Any other?
Yeah, of course. It might be complex.
Yeah. Any other comments or questions? Right. So we're noting that, and then we've got the other minutes from a variety of places for noting. Sorry, I have to say right now I can't see that list. So it's audit committee minutes, isn't it?
Yep.
Has anyone any comments or questions that Andy might be able to answer? Not Andy, Graham. Sorry, Graham, you chair.
Andy's audit.
It's Andy.
It's Andy. Are you REMCOM, Graham?
That's right. Yeah.
Right. Apologies, getting it the wrong way round. So, any comments or questions on these minutes?
No.
No. Lovely. And they're long ones, aren't they? Health and Wellbeing Board. So those are comments or questions to Linda or Nick.
No.
Good. And then it's 2 Health and Wellbeing Boards, isn't it?
Yeah, they're quite old ones now, aren't they? Because
they are 3 Health and Wellbeing Boards. Because we have to wait until they've been finalised, don't we? Primary Care Commissioning Committee. That's any comments or questions to Margaret?
And again, they're old ones. I think the latest one is March. So.
Yeah. Right. Okay. So I think that's all of them. I remember rightly. I should have written down what they were. Yeah, they're all. It's a bit of a catch up, I think, this time round, isn't it? With minutes for noting. Right. Okay. So, date and time of next meeting in public is 16th of September. It says here, conference room A, or it may be streamed. We'll wait and see. We'll confirm that nearer the time.
Can I hand my apologies in?
You can. Yes, we'll let you.
I'm hoping to visit my daughter, so.
Oh, that'd be amazing. Yes. Well, good luck to you. Let's keep our fingers crossed. We're all still travelling by then. Okay. So I will close this meeting formally, and we can stop the live streaming, please.
Yes, I'll just do that now, Chair.
And Jane, the other Jane, you can stop the recording.
Yep, will do.
Thank you.